Dr. Shantanu Abhyankar is there? Because we did not, he's not. Okay, we will move on to the next speaker, and that is Dr. Yashashri Choudhari. Dr. Yashashri, yeah, she is undergraduate and postgraduate from Pune, that is BJ Medical College, and she is settled in UK since last 16 years. She is working in the northwest of England, where she is presently working as a labor ward lead, and she has few modules for the undergraduate students, which is called the lead for family care module, and she is going to talk to us about management of pregnancy in illicit drug users. Is that it? Yeah.
Thank you very much, respected Chairman and the audience. Thank you FOGSI for inviting me to talk on this topic of management of pregnancy in the illicit drug users. So use of illicit drug use with people who are pregnant, as you can understand, causes a lot of problems. It causes medical, psychiatric and social problems. Dependence on these drugs leads to neglect in many areas of user's life. And the situation gets complicated when the patient is particularly pregnant. One can imagine that the injected drug use causes increased risk of acquiring blood-borne infections, namely HIV and hepatitis, as well as abscesses, some heart problems like endocarditis, and the maternal infection and malnourishment are responsible for causing low birth weights, high incidence of preterm births, and poor nutritional status of the neonates. I would emphasize that the multidisciplinary working is very essential. The unit where I work, we have a multidisciplinary team where I work as a lead obstetrician. I have the drug liaison midwife, I have the anesthetist and the neonatologist, and we all together work to give better outcomes for these moms. As one can imagine, management of pregnancy in this population has complex problems. These moms, they have feelings of shame and some stigmata associated with them. It's difficult to know the exact incidents. And 1/3 of these, when you look at the people who are having this problem, 1/3 are reported to be females, and 80 to 90% of these females are in the childbearing age group. Sometimes you have their first presentation, which might not be at the antenatal clinic, but that might be either in labor or presenting through A&E. And we found that this was an excellent opportunity to make them engage with our services. The aim being developing a trusting relationship which will then be which we can maintain for the care of the woman. Particularly it's important because we know that children of these moms, they have behavior and learning difficulties. They have hyperactivity, high levels of irritability, and there are some studies showing correlation between adolescents who use drugs. They are likely to have one or more parents who are drug users. So when we look in detail for the impact of the drug use on children, this is important because these parents, they have impaired judgment and impaired coordination. Because of the drugs they use, they have got disinhibition, which leads to domestic violence. And if they have a withdrawal of these drugs, that causes irritability. There are other social problems like unemployment, which causes poverty. And presence of these drugs in home, having the injecting equipment, is a risk to the children. So in the management, it very much goes with pre-conceptional counseling. The problem being, it's very difficult to get hold of these people. But if you do know somebody who comes for a preconceptional counseling, it's very important to optimize the health before they get pregnant. The signs and symptoms of pregnancy, like nausea, are usually confused with withdrawal effects. So these people, they may not realize they become pregnant. They are often late bookers. They avoid any access to healthcare. And it's very important to have a supportive environment and assurance that we'll keep all the information confidential. I do feel that when they come to the antenatal care, we should be thinking of how we're going to discharge this mom and baby because of the complex psychosocial problems. We should start planning that right the day that we see them. We try to support the woman in addressing these psychosocial issues. There are usually existing mental health problems. In our care, we have usually a model where we allocate these patients to a caseload midwife. This midwife is the key person who links between the obstetrician and the patients. The patients come to know her very well. They develop a good rapport and they then attend the clinics. We can get things done. We can do a lot of things through her, this caseload midwife. We usually ask anesthetic assessment for some of these people who, as you can imagine, have a difficult venous access. And also it's useful to have the anesthetist telling us how we can give them pain relief in labor. The involvement of neonatologist is again another important thing, who can then counsel them about what to expect, how long would be the stay in the hospital, what is meant by neonatal abstinence syndrome, so forth and so on. As one can imagine, drugs are not good for any mom who is pregnant. It has effect on fetal organogenesis in the first trimester, and in the second and third trimester it causes growth problems, preterm labor, neonatal abstinence syndrome, and you also get common associations with some maternal infections. So you do get these moms, they are either HIV, Hep B, Hep C positive, and the long-term effects on the children that we mentioned. So we decided to look in some of these things in detail, and the first thing is alcohol. It's known to be teratogenic, it affects the brain development, and there is a known association with the fetal alcohol syndrome, which is a spectrum of disorder where there is characteristic feces, microcephaly, neurodevelopmental problems, and what we advise the moms is no alcohol is safe in pregnancy. Because that's a common question asked in the clinics. Particularly if somebody drinks more than 15 units per week, these moms are exposing their children to fetal alcohol syndrome. So we advise them accordingly. They have then access to the alcohol treatment services, which involves detoxification, behavior and cognitive therapy. And these neonates who are exposed to these regular excessive alcohol, we monitor them afterwards for withdrawal symptoms and fetal alcohol syndrome. There is some correlation that these infants are prone for neurodevelopmental problems, and some of the children which present with attention deficit hyperactivity disorder have moms who were drinking heavily. So there's a value in having long-term follow-up. When we looked at consumption of tobacco, as everybody is aware, there is increased incidence of miscarriages, again preterm labor, low birth weight, sudden infant death syndrome, and we feel that pregnancy is an opportunity where you can make the mom stop smoking and improve the health outcomes overall. Nicotine replacement therapy is available, and we have sessions which are dedicated for stopping smoking for these moms, and we also like to evaluate whether the partner smokes. Then we come to some of the other illicit drugs like cannabis, and those are the nicknames which are used for cannabis. It's a naturally occurring substance. It can act as a relaxant or mild hallucinogenic, and people can use it either with tobacco, they can smoke it, cannabis on its own, cannabis in a vaporizer, and it causes multiple problems. It causes respiratory risks, it causes throat and lung problems, affects memory, coordination, and it also triggers mental health problems. And it is a drug which can be detected in urine or fatty tissues up to 4 weeks. So it's important when you suspect that your patient is still using cannabis, you can ask her whether she should give a urine sample. It causes low birth weight, sudden infant death syndrome, and developmental problems. Heroin, cocaine, and benzodiazepines are the next 3 drugs that I have included, and they do cause more or less similar problems. Cocaine in particular can be available as a powder, or it's available as a free base called crack. and it causes vasoconstriction, so it's quite famous for causing abruption, preeclampsia, iugia, and cardiac arrhythmias. Then we deal with neonatal abstinence syndrome, and I feel it's important that these women are told in the antenatal clinic for the possibility of neonatal abstinence. They need to understand that their long stay in the hospital might be needed, and depending upon the severity of the abstinence, if it's a mild form of abstinence, then these children, they are looked after in the quiet room, they're given small and frequent feeds, whereas if they have severe symptoms like neonatal seizures, chronic diarrhea, high-pitched cry, then they do need treatment, which is morphine or methadone, and it can last from 1 week to 6 months, so it is quite a debilitating condition. Looking at the use of methadone, which is one of the very accepted treatments that is used in our setup, we feel that this therapy, along with the psychosocial treatment program, improves the obstetric outcomes. We titrate the dose to block the withdrawal and suppress the use of heroin, and it gives the patient some physical and psychological stability. Overall, it gives better birth outcomes and higher attendances at our clinic. There are no known teratogenic effects, and one can commence this treatment as soon as the pregnancy is confirmed. We had some well-maintained stable patients who actually breastfed their babies. One has to understand that sometimes because of increased metabolism in pregnancy, the methadone requirement is increased, and if you don't do that, otherwise the patient will relapse. Buprenorphine is another drug. It's not that commonly used, but it's another one which is used sublingually. It has a long duration of action, which allows dosing every 2 to 3 days as compared with daily dosing. And there are some reports that there is less incidence of neonatal withdrawal, but the reports of safety for use are limited because it's not so commonly used. Looking at what are the other things we can use for people with cocaine dependence, well, there's a wide choice of drugs. There are antipsychotics, antidepressants, dopamine agonists, but there is no drug that will work locally. One can decrease the withdrawal symptoms with use of antipsychotics, and one has to also rely on psychosocial interventions. We would take the similar approach to use for people who are on other stimulant drugs. Some thoughts on benzodiazepine dependence. Again, there are some reports of morphological problems in children with benzodiazepine. Regular use will cause abstinence syndrome, and for the babies, the drug of choice, if they have abstinence, is phenobarbital. And sometimes you might have to agree to have a low dose of benzodiazepine as a maintenance, or if it's a severe case, then detoxification. And along with that, there has to be supportive psychotherapy and anxiety management. So, when we deal with these people, one has to take into account that there is a major part played by psychosocial issues, and one has to also look at how these drugs are affecting the parents along with what is the risk for the children. These are delicate issues, and there has to be emphasis on working together with the parents to maximize the care for children. We have child protection conferences where the key workers, the social services are involved, and we plan for further action. The multi-agency working is crucial, and we hope that the pregnancy acts as a driver for change, and delivery of the healthy baby is a good outcome. And another issue which is important is what are the contraindications for breastfeeding. As one can imagine, these are all lipid-soluble substances. They cross the blood-brain barrier, and we do not advise breastfeeding if the woman is using multiple substances in large quantities. She's using it inconsistently. She's injecting drugs. She's using large doses of cocaine or crack, and is HIV positive. I had 2 of my case studies in this presentation, which I thought would just tell you what kind of population we deal with. So this was a 39-year-old gravida pre-para 1. She had a previous cesarean for fetal distress. She attended our clinics quite infrequently. She was Hep C positive. She was a difficult venous access. The baby was unstable live from 34 weeks. And she complained of constant abdominal pain, where we could not find out why she was having pain. Abruption was ruled out, and this pain was unresponsive to usual medication. She was on methadone, and the growth of the baby was below the 10th centile. She was planned for delivery at 37 weeks, but she was quite erratic in her behavior. Initially, she wouldn't come into the hospital. When we admitted her, she used to go out of the ward, used to still smoke, and we had an episode of collapse of the weekend just prior to her anticipated delivery. She was resuscitated by the anesthetist, and we had planned for her induction with central lab because the lab at that stage had started to stabilize to cephalic, which was then declined by the patient. So we couldn't take any more of all these problems and planned her for a section at 38 weeks. And we also advised her to have tubal ligation, which she refused. So that was one of the cases. The other case is a similar case where there is a history of domestic violence, and this woman presented with choriamnionitis. So I think this is a difficult population where there are complex problems, and I would say that without the team that I have, it would be very difficult to optimize the health outcomes for these patients. Thank you very much.
That was a really unique paper, and we also have a population where they have tobacco, that's a Maseri, which is very commonly used. So there are a good number of smokers also there in our country, and that's why it's worth looking into this kind of paper presentation. Second thing, at least I was not aware of this neonatal abstinence syndrome. Abstinence means I used to always think of family planning. Abstinence, yes, the babies also will have drug abstinence when they are being delivered. So it was really nice and good paper. Thank you very much, madam.
May I now